We are ready.
A really warm welcome to everybody this evening. What's going to be an extremely informative session on membranoproliferative glomerulonephritis and C3 glomerulopathy. It's a really exciting program, and we welcome all our participants. I would firstly like to introduce our mentor and the founder of the program, who's been instrumental to the success of it, Professor Amr El-Husseini, who's going to do a short introduction. He's got many accolades and is currently the medical director of the Division of Nephrology at the University of Kentucky. So, Prof, I want you to take it away to start off this evening's program.
Thank you so much, Professor Nikki, for being very helpful and one of the most active members with us and the board members in the GN program. And you have been very helpful to us in the World Kidney Academy. And today we have a special GN webinar. This is our 6th GN webinar in our fellowship this year. And as you can see, the chairperson is Dr. Nikki Wern from Cape Town University, South Africa. We have our guest experts, Professor Salem Al-Maani from Ohio State University. We have two great speaker and case presenter today, Dr. C3GN and Professor Sajid Bahati. And our organizer and great contributor is Professor Rasha Shimis. So as you know, we are finishing, we have 2 batches in our fellowship. The vast majority are finishing now module 2, and the small batch are finishing module 1. And we are going to start our semifinal exam next week. I want to share with you the success story of the World Kidney Academy Critical Care Nephrology program that we started last week. And also there is a lot of fellows who are part of the GN program who also applied for the critical care nephrology. So this is one of the greatest outcomes and the metrics that I am seeing when I see that the vast majority of our fellows who are doing their fellowship or already graduated from one or another of the fellowship in the World Kidney Academy, they are joining others. So we have fellowship in the CKD, MPD, Transplant Fellowship, GN Fellowship, Critical Care Nephrology Fellowship. And I see the fellows sometimes actually they are combining 2 fellowships at a time. So this means that they can benefit, and they are highly interested, and they are seeing that this fellowship is very helpful to their career. So congrats for those who joined the GN fellowship and also who are combining GN with critical care nephrology fellowship. As you can see, our guest speaker is Professor Salem Al-Maani, the Associate Professor of Nephrology at Ohio State University. He has a very special and unique experience in the GN. He's really one of few experts in the world in different kinds of immune complex mediated glomerular diseases, and also in obstetric nephrology. He has done also a special fellowship in obstetric nephrology in Toronto. He has done his fellowship in Ohio State, and he's back to his home program, teaching, doing a lot of research. He has been publishing a lot, especially in the last 5-6 years. I see that his H index is 23, and he published about 85 articles. Here is our agenda for today. I'm just going to give you this brief introduction. Then we have the first case presentation by Then we have our second case presentation from Dr. Sajid Bahati, also from Pakistan. Then Professor Salem Al-Maani, along with Professor Nikki Wern, and Professor Rasha Samir is going to moderate the discussion. So congrats for those who are finishing module 1, majority of you who are finishing module 2. So module 1 and 2 scientific materials are already done, and we are left with the semi-final exams. So semi-final exams actually starts next week on Monday for 3 weeks. So here is our syllabus for module 1. We started with a general approach for glomerular disease. Then we talked about nephrotic syndrome. Then we have a dedicated week for nephropathology. Then we start to talk about specific diseases and patterns with podocytopathy. And we started with mechanism of glomerular injury, then minimally changed disease, FSGS, and we moved to membranous nephropathy, diabetic kidney disease, and membranous nephropathy. Module 2, we started with a week of nephropathology. Then we focused on secondary glomerular disease, including lupus nephritis, small vessel vasculitis, infection-related GN, onconephrology, obstetric nephrology, amyloidosis, MPGN, C3 glomerulopathy. So again, congrats for those who finish module 1 and or module 2. Then we have the last module that is shorter module because we are going to focus more on the exit exams. So we are having hereditary nephritis and genetic study week, then post-transplant glomerulopathy, then TMA, and the last mini module will be focusing on the standard and advanced and novel therapeutics in GN, and we'll do a review of the whole fellowship program. Then we will have our final exam. Next module starts Monday, July 1st, so be ready. And we will have our next webinar on July 26th. So please share us your interesting cases. We'll be happy to let you present and either to present a case or to do a literature review in our next webinars. And actually, you are giving credits for those who are doing these presentations. The first batch, the vast majority of you are going to be graduated on October 7, 2024. So again, congrats for those who are finishing their fellowship and receiving their graduation certificate on October 7th. The rest will be graduated by the end of this year. Then next year, we are going to start a new batch of fellowship. So we, elected to use the bidirectional way of education and to have a dialogue better than a monologue, because if you tell me, I will forget. And if you teach me, I may remember. But if you engage me and involve me in the education, probably I can retain the knowledge. And because you are special to us, we try to let you be engaged and to return the material we are giving. This is the reason that we have a smart platform and we are trying to teach you through this smart form and to get you engaged and involved in the educational material. So you probably can retain this information and can apply and disseminate this knowledge in your clinical practice. And with that said, I'm going to stop by here. And I will let Dr. Nikki and Dr. Rasha to moderate the session.
Thanks so much, Prof, for that great introduction. So on that note, I'm going to warmly welcome Dr. C3GN, who's a professor of nephrology at Sindh in Institute of Urology and Transplantation in Pakistan. She's going to start with the first presentation and discussion, and we really look forward to your presentation. Thank you very much, Sidra.
Please unmute yourself, Sidra. Sidra, unmute yourself. You are muted.
Assalamu alaikum. Can you hear me now?
Yes, we
We
do.
can hear you really nice and clearly, Sidra. Thank
Okay.
you.
24-year-old male patient, resident of Shahdadpur, student of BS Agriculture. He presented to us for the first time in emergency on 19 Feb with the complaints of headache, decreased appetite, and nausea and vomiting for the 1 month. According to patient, he was in his usual state of health 1 month back when he gradually developed headache, which was mild, bilateral, band-like, and it was 3/10 on severity scale with no specific aggravating and relieving factors, and it does not radiate. However, it is not associated with lacrimation, rhinorrhea, any neurological deficit, seizures, fever, or visual disturbance. It was associated with decreased appetite, nausea, vomiting, which were initially 1 to 2 episodes per day, but gradually increased to 3 to 4 episodes per day containing food particles, non-projectile, half cup in quantity, not blood stain. For these complaints, he went to nearby clinic and seek medical advice. He found to have raised pressures and deranged renal functions, for which he visited to SIUT hospital. His past medical, surgical, and transfusion history was not significant. His personal history was not significant except for decreased appetite and sleep. Addiction history was nil. Family history was not significant for any comorbid conditions like diabetes, hypertension, renal disease, or any other chronic illness. Transfusion history was not significant. On systemic review, there was no significant history in the CNS like photophobia, lacrimation, focal neurological deficit, or fever. There was no history of palpitation, shortness of breath, chest pain, body swelling. No any significant history of abdominal pain, diarrhea, yellowish discoloration of skin or sclera, and no any complaints of cough or hemoptysis. Musculoskeletal, there was not significant. In renal system, there was history of frothy urine only, but it was not associated with cola-colored urine, burning maturation, or any lower tract symptoms. He was young male, lying comfortably on bed, well-oriented to time, place, and person. On vitals, he had a raised pressures of 163/95. Pulse was 95 beats per minute. Saturation was 99% on room air, and he was afebrile. However, he was anemic on clinical examination. Central nervous system, cardiovascular, chest, and abdomen was not significant. Nothing important in this on his examination. We went for initial lab investigation and found to have hemoglobin of 9.2 with normal coagulation profile. However, his renal functions were markedly deranged, urea of 136 and creatinine of 5.5. However, biomarkers were negative and serum albumin was 3.2. His urine DR showed albumin of 4+ and RBCs 3+, and spot PCR was 7.7. On ultrasound, his kidneys were bilaterally normal size with slightly raised echogenicity. ECG showed no LVH and no acute changes. Chest X-ray, it was normal, no active lesion. How should we proceed next? We admitted the patient, started him on oral antihypertensive drugs, and echocardiography was done to rule out the LV hypertrophy, which was normal with normal posterior wall thickness and preserved systolic function. Fundoscopy was done to rule out any hypertensive retinopathy. It was normal, and serology generated during his hospital stay. In the serology, we got ANA anti-dsDNA done, which was negative. C3 was markedly low. We have a normal range of 0.7 and we got it 0.1. C4 was normal, ANCA was negative. How should we proceed next? What should we do further? As he has a proteinuria, active sediments with renal dysfunction and no hypertensive changes on fundoscopy, so we went for renal biopsy. This is a renal biopsy, which is a light microscopy PAS stain, and it is showing glomeruli, which are globally sclerosed glomes. High power view, same light microscopy, high power view, PAS stain, and globally sclerosed glomeruli. So single core of renal biopsy was done, consisting of only cortex up to 16 glomeruli. Out of 16, 14 were globally sclerosed and 2 show mesangial expansion with intramembranous deposits, no vasculopathy. Tubules, moderate to severe tubular atrophy, and interstitium showed dense interstitial inflammation. IF was done, which showed granular positivity of C3 while rest was negative. We do not have a facility of protease dilation to unmask the monoclonal immunoglobulin deposit, so it was not done. Here it is only isolated C3 deposition on the IF. So we requested for the electron microscopy, and this is the electron microscopy. Here there are some intramembranous deposits, and in this area we have got mesangial deposits. These are mesangial deposits. So EM showed a proportion of glomeruli with large discrete deposits in the mesangial and intramembranous location. So our final diagnosis was chronic sclerosing GN secondary to C3 glomerulonephritis. Okay, so C3 is basically a disease of alternative pathway. So if we go through the pathway, what happens is there are three kinds of pathway: classical pathway, alternate pathway, and lectin pathway. Classical pathway is activated with the help of antibodies. They combine with the antigen and antibody complex. Lectin pathway recognizes the MBL mannose binding lectin. However, the alternative pathway, what happens in this pathway, there is a hydrolysis of C3. It combines with water and factor B. When it combines with water, there is a modification in its structure. It increases its intensity to bind with the factor B. Factor B, now what does factor B and C3 do together? Factor D hydrolyzes the factor B to form the C3 convertase. This is initial C3 convertase. It converts the C3 into further C3A and C3B. This C3B now combines with C3 and factor BB to form the amplification loop, and further factor B keeps on adding and it forms a C5 convertase. So this factor BB keeps on adding and it creates an amplification loop, and in final there is a formation of membrane attack complex which do the hydrolysis, which do the lysis, and there's a activation of inflammatory cascade. So there are certain pathway, there are certain abnormalities at which alternative pathway can get affected. What kind of abnormalities we get in this alternative pathway? Either we can get the factor H deficiency. There are three main roles of factor H. Either it hydrolyzes or it spontaneously dissociates the factor C3 convertase, or it inhibits factor B to combine with C3B to form C3 convertase, or it combines with factor I to inhibit form of C3B. So either we can get the deficiency of factor H, either we can get anti-factor H antibodies, or either we can get C3-NEF. C3-NEF is basically autoantibodies which stabilizes the C3 convertases, and it prevents its spontaneous dissociation. When it stabilizes the C3 convertase, it keeps on dissociating the C3 into C3A and C3B, and this C3B then it creates a vicious circle and creates an amplification loop, and it remains activated. And in serum we get the low C3. So MPGN is basically not a disease. It is a histological pattern of a disease. Whenever we get MPGN, we should dig out the underlying cause. And on the basis of IF, immunofluorescence, we can get the clue of the underlying disease. If there is an immunoglobulin deposition along with the complement, we should look for any infection, any autoimmune disease or lymphoproliferative disorder, or it could be idiopathic MPGN. If there is isolated or dominant C3 deposition without any immunoglobulin, then there is a C3 glomerulopathy. It is a broad term. It includes two basic entities: dense deposit disease and C3 glomerulonephritis. C3 glomerulonephritis accounts for about 66% of C3 glomerulopathy, and dense deposit disease, it accounts for 33% of the C3 glomerulopathy. So what should we do next for our patient? We went for a certain investigation. As I told you before, there are at certain levels, we can get the abnormalities in the alternate pathway. We go for factor H, it was normal. Anti-factor H antibodies were absent and C3-NEF was negative. We do not have a facility of C5 nephritic factor, so we could get these investigation done. How should we proceed next? This is a optical coherence tomography, and what is it showing? It is showing the lumpy, bumpy appearance of retinal brush membrane. Why this? It has a lumpy, bumpy appearance because just like in the kidney, we had C3 deposition, same in the retinal brush membrane, we can get the deposits over here as well. And it is indicated in the form of drusens. So OCT showing lumpy, bumpy appearance of brush membrane. So as this patient had a very advanced disease, out of 16, we had 14 glomeruli were globally sclerosed. We did not plan for any further immunosuppression. Rather, we discharge him on AVF appointment and call him for pre-transplant OPD workup. And we did not subject him for the further immunosuppression. Thank you.
Thank you very much, Sidra, for that excellent presentation. I'm going to introduce Professor Salem Almani, who's going to help me moderate the session and answer anyone's specific questions. I did see in the chat that something came through, so I'm just going to have a quick look. So I'll just read what's so I guess that I'll just start off by saying that the first question was paraproteinemia should be investigated, but from what Sidra demonstrated, that goes more down the other arm of the membranoproliferative cascade. But Prof. Almani, would you like to comment on that and perhaps just pick up some of the important points of the case?
Yeah, so thank you for having me. So a couple of things. I mean, obviously in this case, we're going to probably go through the workup of MPGN in general with the next couple of cases. But this is, C3 glomerulonephritis or glomerulopathy or DDD is basically presents as an MPGN pattern. And the reason for it happening is excessive complement pathway activation. And the way, when I think about it, the way I conceptualize it, it's either usually due mutations in genes that either are involved or regulate the complement pathway, C3 being the most common, or it is because of the presence of autoantibodies that either stabilize the convertases, such as C3 convertase, C3 nephritic factor does that. There's a C5 convertase, and C5 nephritic factor can do that. And there were reported cases actually of a C4 nephritic factor, which stabilizes the C5 convertase that was sort of assembled by members of the classical and lectin pathways. Now, those are one form of antibodies, but you can also have antibodies that attack things that are supposed to, put down the brakes on a complement activation, such as factor H and the CFHRs. So that is how I conceptually think about this. And when it comes to treatment of those entities, you have to keep that in mind, because a lot of times, we used to go for non-specific decrease in targeting immunity sort of non-specifically with things like CellCept, or trying to clear antibodies with things like plasmapheresis. But now we have more targeted therapies that are gonna come up pretty soon. So factor B and factor D inhibitors. Now, one thing that was tried in, so we've had eculizumab for a while, and it seems to, as you know, inhibit the cleavage of C5, but it seems like the damage in C3GN and dense deposit disease are not really mediated by the membrane attack complex. And that's why we have seen that some patients do respond to it, but many do not. So there's more therapies coming down the road. Now, if there is an antibody that you can, most of those are IgG antibodies. So that's why some people try to address the autoimmune or autoreactive B cells that produce those antibodies. So if you have a C3 nephritic factor, a C5 nephritic factor, stuff like rituximab has been trialed to see if you can, kill those B cells that produce those autoantibodies. And in terms of diagnosis, I mean, this patient has isolated C3 deposits, but the sensitivity, you'll get better sensitivity if you diagnose C3GN by going with what we currently use, which is a C3 staining that is 2 magnitudes more than IgG staining, meaning that if you have 3+ C3 on the biopsy, but you have a +1 IgG, that sort of qualifies as a C3 predominant GN, and you would go the complement route. And a lot of times the IgGs are masked, and this is why we do protease digestion to see if there are some masked deposits, because that makes those IgGs more accessible to staining. I mean, I'll probably stop there and see what questions do we have.
So, that's fantastic. And I think it has answered some of the questions. So I'm just going to go through some of the questions from the floor. The first question was, what is the difference of C3 in membranoproliferative GN and C3 glomerulopathy associated with a monoclonal gammopathy?
Yeah, so that's a great question. The thought is that in C3, like real C3 or isolated C3 without monoclonal gammopathy, we think that, it's the same things that we talked about, autoantibodies and complement gene mutations. Now, in C3 glomerulonephropathy that's associated with a monoclonal antibody, it is thought that those either monoclonal antibodies or a polyclonal antibody that is produced as a paraneoplastic antibody is the antibody that stabilizes the convertases. And hence, treating the monoclonal gammopathy or killing the B cells or the plasma cells in this case would be the route to go. So it is somewhat conceptually similar, but the thought is that the gammopathy or the monoclonal protein or paraneoplastic polyclonal protein is the reason that the complement system is being aggravated.
Okay, I'm going to ask the next two questions, which kind of relate to one another, and it's about transplantation. And the first one is, what are the chances of recurrence of transplantation? And the second question was, with planning for transplantation, may she need eculizumab to prevent recurrence? I think they're quite important questions.
Yeah, so those are great questions. So the chances of recurrent post-transplants are pretty high. There are case reports of upwards of 50%. So this is very, very common. The recurrence is very common because, if it's a mutation, it persists. It does not, the new organ does not come in with its new complement proteins usually. Now, eculizumab has been trialed with some success. But as we discussed a little bit earlier, it does not. It seems like most of the driver of disease may not be the terminal complement pathway, which is C5 and all the way to the MAC, and thus it has not been very successful. Now, in patients who responded to eculizumab, it would probably be a good idea to keep him on eculizumab or before a biopsy. In the US, we do transplants in patients with a GFR less than 20, so some of them are still not on dialysis. But if they did not respond to eculizumab the first time, then chances are they may not respond the second time or post-transplant.
Excellent. I'm going to, and we've answered some other questions along the way. There is a question from one of the audiences that wants really to know the difference between sort of the dense, I'm assuming from the biopsy, of dense deposit disease and C3 glomerulopathy, and how do you tell the difference between the two?
Yeah, so the biggest difference is how much deposits are there. In dense deposit disease, there are very large, what we call sausage-like deposits that are not seen in C3GN, which is more associated with sort of scattered deposits. So, that is the biggest difference. And yes, drusen is seen more with DDD, way more than C3GN.
Yeah, and that was kind of that EM was those deposits were quite more not as sort of like densely arranged from my understanding. Okay, so I'm going to introduce my co-chair. I think we've finished with all the questions. The last question, if we could quickly just answer that, was about genetic testing. I know some of the genetic testing was done. I guess my question would be, how far do you go with genetic testing?
So it depends on your resources. We collaborate with the University of Iowa, which has a large complement center, and they do next generation sequencing on all complement genes. So, and that's what we do. So we do that genetic testing, and we measure factor H, factor I antibodies, as well as the C3, C4, C5 nephritic factors. But most of the mutations have been reported in the C3 gene and the CFHR genes. So those would be, you know, if you have limited availability, those would be the ones to go for.
Yeah, I guess that was a very important point you brought up, that not everybody has the resources. So we all have to do what is actually possible in our own clinical environments. I'm going to leave the rest of the questions because I'm sure some of them will filter into the next presentation. And I'm going to hand you over to my co-chair, who's going to introduce the next case presentation. I'm going to introduce Professor Rasha Shamiz, who's a colleague of mine and a friend. And Rasha, I'll let you take it over from here.
Thank you so much, Nikki. It's my pleasure to introduce Professor Sajid Zabati. He's a professor of nephrology at Sindh Institute of Urology and Transplantation in Pakistan. He's as well an artist. His proficiency in stone painting elevates natural elements into stunning masterpieces with meticulous care to details and design, as in nephrology as well. Dr. Sajid, please go ahead and share your presentation. And for the floor, please feel free to share your comments and the questions into the chat box.
Hello. Hello.
We can hear you nicely.
Okay.
Just need to put it on presenter view.
Yes. Can you see the
Excellent. It's
presentation?
all ready to go. Yeah.
Yeah.
Okay. So, good evening, everybody. I'm Dr. Sajid Bhatti from SIUT, and there is a case presentation of a 53 years old male who was resident of Karachi. He was married, father of two, came to SIUT as an outpatient in September 2023 with complaints of worsening of lower limb edema and shortness of breath for the last 2 weeks. So he was in his usual state of health 2 weeks back when he noticed increase in the lower limb edema, which progressed up to the knees in 2 weeks. There was shortness of breath, mostly on moderate exertion. He denies history of typical chest pain, palpitation, cough, sputum production, decreased urine output, any high-colored urine. There was no history of seizure, no history of diarrhea, no history of abdominal pain or body rash. 2 weeks prior to visiting outpatient clinic, that is in September 23, 2 weeks before, he got treatment for lower respiratory tract infection from a local facility. And at admission to that particular hospital, his serum creatinine was 1.2. When he visited SIUT after that treatment, his serum creatinine was found 4.5 milligram per deciliter, along with serum albumin of 2.8. So past medical history, in December 2022, he presented to an outside facility with high blood pressure, bilateral lower limb edema, proteinuria of 4.8 gram per 24 hours, and serum creatinine of 1.3. Underwent renal biopsy at an outside facility and diagnosed to have mesenteric GN. He was advised tablet prednisolone 1 milligram per kg per day from December 22 to February 23, almost 2 months, then tapered to 10 milligram per day progressively. He was given tablet MMF 750 milligram BID from May to September 23, along with antihypertensive treatment of amlodipine, combination of amlodipine and valsartan, furosemide 40 milligram per day, along with proton pump inhibitor. His past surgical history is significant. He underwent appendectomy in 1982, operated for right inguinal hernia in 2012, had a varicose vein ligation in September 22. Family history is not significant, and father had diabetes and ischemic heart disease, but none of the family members had a kidney problem. He was ex-smoker, but quit smoking 5 years back. There was no significant, in the personal history, there was no significant history of weight loss, although he gained 6 kg of body weight in the last 4 weeks since when he started in having increase in the swelling of the body. His bowel habits, micturition were normal, but sleep was disturbed since recently. There was no history of use of illicit or recreational drugs. So on examination, he was a middle-aged male of normal build. He was lying comfortably on bed. He was conscious, active, and oriented in time, space, and person. He was anemic. He had edema. JVP was not raised. Pitting edema was present at both lower limb and it was extended up to the knees. Blood pressure was high. There was regular pulse. He was afebrile. Saturation was normal at room air and reflow was normal. Systemic examination was almost unremarkable. Respiratory system. There was no added sound on cardiovascular system. Abdomen was soft. There was no palpable visceromegaly, and CNS was grossly intact. So the kidney biopsy, which was done outside in December 22, there were 12 glomeruli, and there was diffuse mesangial and endocapillary proliferation with thickening of the capillary loops showing segmental double contour in all glomeruli. There was no crescent or necrosis at the time of biopsy. There was moderate chronic interstitial inflammation with patchy mild degree of atrophy and interstitial fibrosis. Few tubules on that biopsy showing proteinaceous scars, and the blood vessels included in that biopsy were unremarkable. This biopsy had been done outside in December 2022. 9 months prior, he presented to us with increasing edema. The immunofluorescence of that outside biopsy shows the full house positivity. So if we go through the investogram and his treatment in this particular slide, we can see that in December 22, he had a serum creatinine of 1.3, and he had been biopsied because of proteinuria and abnormal serum creatinine, and that creatinine improved to less than 1 with some improvement in serum albumin. He was taking prednisolone at that time. When serum creatinine rose to 1.5 in April 23, MMF was added to the treatment. The serum creatines almost stays same with decline in the serum albumin level, and he was taking prednisone and MMF. Serum creatine was marginally improved in almost 3 months after introduction of MMF, and it improved from 1.5 to 1.3 with some improvement in serum albumin, and he was continued to take prednisone and MMF. So when he was admitted in outside facility in September 23 with the lower respiratory tract infection, the creatinine after discharge rose found to be high, 4.5, and this is the reason he had been presented to us with increasing body swelling, increasing serum creatinine, and persistence of hypoalbuminemia. His serology done outside when he had renal biopsy done in December 22, he had a marginally low C3 and marginally low C4. ANA was negative, while the viral serology was also negative for hepatitis B, C, and HCV-RN was also not detected. He was more than 50 years of age, investigated for paraproteinemias, and kappa chain, lambda chain was found high, but the kappa and lambda chain ratio was normal as per his GFR. IgA, IgM, IgG level was unremarkable. So to summarize this case of 54 years old gentleman, he had a biopsy done in December 22 with a serum creatinine of 1.3. He was given prednisone, serum creatinine improved to 0.8. Serum creatinine rose to 1.5 in May 23. He was the prednisone coupled with MMF. And along with MMF, there was some improvement has been observed. And this continued till September 23 when he has been infected with some pneumonia-like symptomatology. It required hospital admission, and later on he developed worsening of the GFR and lowering of the serum albumin along with increasing body swelling. So in September 23, he presented to SIUT with all above complaints. So what could be the reason of increasing serum creatinine from one improving pattern of 1.3 to 4.5? What should be done next in this particular patient? So can someone suggest what we can do in this patient, what we have to do in these patients who are going stable and then serum creatinine rose from 1.3 to 4.5? What should be our approach?
Just because most people are muted, I'll just perhaps put them in the chat, but I'll say one question was to repeat the biopsy, one response.
Okay, I am looking into like some everybody's agreed with we go for a repeat biopsy. That's fine.
Yeah.
We also plan to go for repeat biopsy, and we perform some baseline investigation as a prerequisite for the admission and preparing for the biopsy. Was found to have a low hemoglobin, which was more than 10 at the time of admission. Normal INR, urine DR showing proteinuria and microscopic hematuria. Urine culture was negative. So his spots urine protein to creatinine ratio was more than 3, but his urea was more than 200, 4.5 creatinine. Patient had normal serum but high phosphorus because of increasing GFR. He had a low total protein, low serum albumin, and AG ratio was 1.4. His LFTs were normal. LDH was also normal. Magnesium was high. He had, because he was admitted with pneumonia, he performed chest X-ray, and you can see inhomogeneous ground glass appear in the right upper zone. There is no other pathology seen on the chest X-ray. This ultrasound showed both kidneys are of normal size, non-hydronephrotic. They are of slightly echogenic texture. Echocardiography was done and shows good systolic function with the ejection fraction of 70%. IVC was 1.6 centimeter and more than 50% was collapsing. There was some sign of mild left ventricular hypertrophy, and the LA was mildly dilated. Serology was done as part of the prerequisite of registering this patient, and patient has got a unremarkable immunoglobulin G, M, and A. C3 was again found to be normal. C4 was found low. ANA was negative. R effector was negative, and ANCA was negative. So what should we do next? You people are already said that we have to go for a repeat biopsy, or another thing that can be changed the immunosuppression at this time when we know the disease already had a biopsy done, and but I think so everybody's agreed that we should go for a repeat renal biopsy in this particular patient. So we did repeat renal biopsy, and this was a low power. There was 2 core of renal biopsy. There was mild interstitial inflammation. The glomeruli you see are hypercellular and lobulated. So this is a medium power view. There's an interstitial inflammation you can well recognize in this lower part around this gloom. There are infiltration of the cells. But you can see the gloom is hypercellular, lobulated, and there was loss of capillary lumina. You can see there was pink staining of material seen in some capillary lumina here and in the basement membrane as well. The glomeruli looks lobulated and hypercellular in all areas. Another view, and we're showing the lobulated glomeruli, cellularity is increased. This is a high power view, and you can see that there is pinkish material seen in the basement membrane, and which we know that this is a wire loop appearance seen in patient who had got in certain glomerular diseases. And these are the wire loops lesions. There's another high power view, and you can see these pink hyaline acellular material in the capillary lumina, and these are called hyaline thrombi. So to summarize this biopsy, there was 2 glomeruli was globally exposed. I'm going to show one thing more, that this patient has some crescent formation as well in in 2 of the glomeruli. So 2 glomeruli are globally exposed out of the 18. Rest showed mesentocapillary pattern with florid hyaline thrombi, which is seen. There was focal cellular crescent in the 2 glomeruli, but immunofluorescence panel was negative. Unfortunately, the immunofluorescence was done in the sclerosed glomeruli. So anybody can tell that what is the differential diagnosis of having hyaline thrombi in this particular patient?
Just put them in the chat. So the first person said cryoglobulinemia. Second
Yeah.
said TMA. We have a couple of cryos.
Mhm. So it's YTMA. I don't know.
Did we get sorry, just a question. Did we get the hepatitis C serology?
Yes, we had a negative hepatitis
Negative.
as
Yeah.
the antibody and HCV-RNA.
Okay.
So potential diagnosis of hyaline thrombi, them saying that there may be some cryoglobulinemia or TMA. Okay, so they may be seen in the EPLA. Cryoglobulinemia, yes. You can see in the lupus nephritis and HCV-related G. So what should be our next step? We have a kidney biopsy done. Patient has got mesenteric capillary pattern, and there was a wire loop region along with hyaline thrombi obliterating the capillary lumina, and the glomeruli are hypercellular, lobulated. They were present in 2 out of the 18 glomeruli. Patient had abnormal serum creatinine of 4.5.
The suggestion is you do the antiphospholipid serology and serum cryoglobulins.
Okay. So what should be, so in view of the present of, first of all, because this patient has diagnosed to have rapidly progressive GN, there was recent in the biopsy, and patient had abnormal serum creatinine. The kidney biopsy was hypercellular. So patient was given first dose of cyclophosphamide on 5th of October 23. Cryoglobulin levels were advised along with the repeat viral serology for hepatitis B and C, although it was found negative earlier. So cryoglobulin level was found positive. Cryoglobulin levels was very high, and immunosuppression electrophoresis was done, which was found positive for type 3 cryoglobulin. EPLA was negative, ANA negative again, ENA negative, serum protein electrophoresis, urine protein electrophoresis was negative. Kappa chain, lambda chain ratio was within normal limit as per his GFR. His, in view of the presence of high cryoglobulin level, and there was, and the immunofixation pattern was positive for type 3 cryoglobulin. He underwent HRCT, which does not show any interstitial lung disease. There was only mild ground glass haze in the right upper lobe of the lung, which we seen earlier on the chest X-ray. There was mild bilateral pleural effusion. There was no cystic or bronchial changes in either of the lung field, and lymph nodes were subcentimetric and they were few. Also, during the admission, he developed this non-blanching palpable purpuric rash over the lower extremities. So, as etiology remained unknown, cryoglobulinemia occur in the absence of well-defined disease categorized as essential mixed cryoglobulinemia. Patient was subjected to anti-CD20 treatment along with prednisolone. Patient was given 2 doses of rituximab, 1 gram each was given in the interval of week 1 and week 3, although the second dose has to be given on day 15, but patient had some reservation for second dose. He come late and for the second dose. So the second dose was given at week 3. So after almost 5 weeks of initiating treatment, hemoglobin has been improved, white cell count stays normal, platelet normalized, serum creatinine was smoothly improving towards the baseline of 1.8 from 4.5. Serum albumin although remained low, and the cryocrit level improved from 3.5 to 0.5%. So if you go to the review of literature of a patient who has got cryoglomerular vasculitis, while taking the history of the patient, we have to ask few things, and at least two of the following items should be present. That we should ask, do you remember one or more episode of small red spots on your skin, particularly involving the lower limbs? If you remember, this patient had been operated for varicose vein, and we do not know what was that. I think so, maybe something like that. Have you ever had red spot on your lower extremities that leave a brownish color after their disappearance? Has a doctor ever told you that you have a viral hepatitis? The clinical item, at least 3 of the following 4 present or past. Constitutional symptoms like fatigue, low-grade fever for more than 10 days. There should be no other cause like sore throat, diarrhea, some skin lesion, etc., etc. Fibromyalgias, articular involvement, vascular involvement like purpura, skin ulcer, necrotizing vasculitis, hyperviscosity syndrome or Raynaud phenomenon. Is there any neurological involvement like peripheral neuropathy, perilevel involvement or vasculitis? The laboratory item, at least 2 of the following 3 should be present, like reduced serum C4 in our patient. You see that patient has a very low C4 level. It was also low when he was first presented to the outside facility. It was marginally low, and when he came to us, he was found to have very low C4 level along with normal C3. Positive serum rheumatoid factor, positive serum M component. The treatment algorithm for the initial therapy of essential mixed trichoepithemia include that sorry. Moderate to severe disease that the patient have hepatitis B or HIV infection. Mild disease is treat-associated underlying disorder if present. Immunosuppressive therapies is usually not required. So if disease is moderate to severe, if this patient has systemic, if severe, yes, systemic glucosteroid plus rituximab, initiate antiviral therapy before or at the same time as immunosuppressive therapy. If patient does not have hepatitis B or HIV infection, systemic glucocorticoids plus rituximab, initiate treatment of the associated underlying disorder if present after disease stabilization with immunosuppressive therapy. So in both conditions, in patient who has got associated hepatitis B or HIV infection, the immunosuppression also should coupled with the antiviral therapy. But in patient who has got a negative hepatitis B or HIV or HCV infection, we should initiate treatment of the associated underlying disorder if present after and after disease stabilization with immunosuppressive therapy. So in patient who has got hepatitis B positivity or HIV infection, and in which we have started with the systemic glucocorticoids and antiviral therapy, does the patient have any of the following clinical indication for plasma exchange as well, like systemic hyperviscosity syndrome due to mixed hyperviscosity syndrome, life-threatening disease manifestations like acute respiratory failure, pulmonary hemorrhage, rapidly progressive GN requiring dialysis. severe refractory skin ulcer due to cutaneous vasculitis, high cryolytic level of more than 10% prior to administration of rituximab. So if this patient has all these symptomatology of hyperviscosity of life-threatening disease manifestation, one should start with the plasmapheresis along with the high cryolytic level. So there was a case report of essential mixed hyperuremia from SIOT earlier, and I was one of the person who was involved in this case report. The incidence of EMC is high in the region where there are comparatively low HCV infection burden and low in areas of high infection prevalence, including HCV. So despite a strong association of mixed hyperuremia with HCV infection and other causes that leads to cryoglobulin formation, essential mixed hyperuremia remains a separate entity. There was another case study of mixed cryoglobulinemia associated with peripheral neuropathy, and patient presented with sensory motor neuropathy and with feature of mononephritis multiplex syndrome, but which lacked other classical feature. Profile of that patient was typical of mixed globulin, immunoglobulin M paraproteins, and low C4. There was positive rheumatoid factor as well. So this case demonstrates the need to include cryoglobulinemia in the differential diagnosis of peripheral neuropathy and the critical importance of using a correct collection procedure to isolate cryoglobulins. Here we report a case of 24-year-old male diagnosed treated as mixed cryoglobulinemia in the setting of juvenile idiopathic arthritis as well. This was improved with the initiation of rituximab and methotrexate. So there was an article which was published in 2022 in Expert Review of Clinical Immunology, and as per this study, treatment strategies should be individualized based on the underlying etiopathogenesis. So the severity of organ involvement and the associated underlying disease. At present, the two mainstay of cryoglobulic vasculitis treatment are direct antiviral agent for HCV-related GN and the B-cell targeted therapy. Moving forward, the primary challenge will continue to lie in the treatment of resistant or refractory cases of cryoglobulic vasculitis, particularly those associated with autoimmune disease or cases classified as essential cryoglobulic vasculitis, like in our case. So this is all.
Thank you very much, Dr. Bhatti. That was just an excellent presentation. We are a little bit behind time, so we're just going to save your questions, but also, Dr. Bhatti, if you wouldn't mind having a look at the chat and perhaps we can answer some of the questions via email. We can forward the answers via email at the end or sometime after the presentations are finished. So I'm just going to go to the final case now. So I think take it away.
Shall I start?
Please start.
Assalamu alaikum again. So I'm presenting another case, a 27-year-old female with married with one child. She is deaf and dumb by birth, resident of Karachi, presented to us with a complaint of fever, sore throat, and generalized body swelling for 1 week. Fever and sore throat were for two weeks and swelling for 1 week. According to patient, she was in usual state of health 1 week back when she developed low-grade fever, undocumented, not associated with rigors and chills. It was temporarily relieved by taking antipyretics. However, it was associated with sore throat, no cough or hemoptysis. After 7 days of the above-mentioned complaint, she developed bilateral pedal swelling, extending up to knees, followed by periorbital swelling. There was no associated complaint of orthopnea, nocturnal dyspnea, or shortness of breath. She has a frothy urine along with pedal edema, no complaint of hematuria, cola-colored urine, joint pain, oral ulcer, hair fall, photosensitivity, or rash. In short, there was no any autoimmune history. For these complaints, she seek medical advice and found to have raised creatinine with active sediments in urine to refer to SIUT hospital. Her past medical, surgical, drug history, allergy history, and personal history was not significant. Addiction was nil, and family history was not significant for any comorbid condition. Transfusion history was nil. Her obs and gynae history were fine. She had regular cycles, and rest was not significant. Young female lying comfortably on bed, well oriented to time, place, and person. She was vitally stable, and on general physical examination, she had only edema of 2+ up to shins. Systemic examination was unremarkable. So how should we proceed next? We collected her initials, which include the CBC, and the complete blood count was normal with normal coagulation profile. However, her renal function, serum creatinine of 1.2 with a dip in serum albumin of 1.8, while markers were non-reactive. She had a high lipid profile. Triglycerides were markedly ranged along with LDL. Urine analysis revealed albumin of 2+ with RBCs occasional and pulses numerant and spot PCR of 6.4. She had normal sized kidneys with slightly raised echogenicity. Serology was generated, which shows negative ANA and dsDNA. C3 was 0.4. It was less than normal, and C4 was normal. Since she presented with the fever, sore throat, and body swelling, there was high suspicion of post-infectious GN. So we went for a non-invasive test, ASOT, which was negative. And unfortunately, we were running out of kit for anti-DNSB. So we proceed for renal biopsy. This is a renal biopsy which showed low microscopy, low power view light microscopy, PAS stain. And in this, you can see we cannot appreciate the Bowman's space. The Bowman's space is completely obliterated by extracapillary proliferation. Capillary lumina are obliterated by intracapillary proliferation. So capillary lumina are obliterated. There is a both intracapillary and extracapillary proliferation along with the fibrous crescent over here. High power view, same findings. The Bowman's space is obliterated with extracapillary and intracapillary proliferation. We cannot appreciate the capillary lumina, and there is a fibrous crescent. There is a fibrous crescent, and here there is a salar crescent. Similar findings. So 2 cores of renal biopsy consisting of cortex and medulla up to 24 glomeruli. Out of 24, 2 show only globular sclerosis with fibrous crescent. Rest show mesenteric capillary pattern. 7 out of 24 show salar crescents. 3 by 24 show fibrous salar crescents. Mild pachytubular atrophy was seen. IF was done, which showed diffuse positivity in the mesenteric along the peripheral capillary wall of C3 2+, while rest was negative. So we proceed. What should we do next? Either we should treat this patient or we should leave. As she had a crescent, so we treat her with methyl pulse, prednisolone, followed by oral steroids, and we gave her IV cyclophosphamide 500 mg with pre-medication. She received 2 doses of IV cyclophosphamide, and meanwhile, we requested for electron microscopy. She was given antiproteinuric and diuretics and Cepton DS prophylaxis for PCP. So we generated her EM, and as you can see, in the case number 1, there was ill-defined discontinuous infiltrates in the mesangial and the intramembranous area. There's a thick, defined, continuous intramembranous deposit. The GBM is thick. So these are ribbon-like dense deposit, and the name indicates this is a completely bookish picture. This is a dense deposit disease. Thick, well-defined intramembranous ribbon-like deposits. EM showed a portion of glomeruli with intact lobular architecture. There's a dense transformation of lamina densa of the GBM with diffuse effacement of the overlying foot processes. Findings are suggestive of dense deposit disease. What to do next? As I told you before, there are certain, at certain level, we can get the complement, abnormal complement pathway. So we requested for anti-factor H antibodies, which were negative, along with C3 nephrotic factor, and her factor H levels were above 600. Eye examination was negative for drusen. It is very unusual. Drusen is usually associated with dense deposit disease and less likely with the C3 glomerulonephritis. But in our case, we get with the C3 glomerulonephritis rather than dense deposit disease. After getting EM report, she was switched to MMF along with Cardase, and her follow-up creatinine showed a decrease from 1.2 to 2.8, and there is increase in serum albumin from 1.8 to 2.4. This picture I have explained before as well. So when we get the dominant C3 staining, we get the following, we have to make the following differential diagnosis. Either it could be C3GN, it could be dense deposit disease. If a patient is above 50 years of age, we should think for the monoclonal gammopathy of renal significance or PIGN. In post-infectious GN, the C3 levels, we can get normal C3 levels in 6 to 8 weeks, but if there's a renal dysfunction and levels get not normalized, so we should proceed for the renal biopsy in PIGN. So the differentials for the dominant C3 staining, these 4 are the differentials. And these are the laboratory workup. If we have a facility, so we should go for this laboratory workup. And according to this, this is a primary C3GN. If there is a dominant C3 staining, or if there is a monoclonal with a complement deposition, so we should screen for this complement disease antibodies or factor deficiencies. Along with that, we should start with the renoprotective treatment. If there is a stable or slowly progressive disease with proteinuria of less than 1 gram, we should treat it on conservative like renal lipid profile and renal functions. And if there is a nephrotic syndrome with renal dysfunction, crescents, we should consider steroids plus MMF. And there is a role of eculizumab as well, but it is not well established. So now there are novel treatments which act at a certain levels, just like iptacopan, it acts on the factor B. Pegcetacoplan, it acts on the factor 3. Eculizumab, it acts on C5, factor 5, C5. And avacopan is a C5 receptor inhibitor. So these are novel treatment for the C3GN, and they are under trial. So as far as transplant is concerned, there is 100% recurrence with the dense deposit disease. However, the graft loss is more with C3 glomerulonephritis. Recurrence of C3GN is over 50%, while dense deposit is 80 to 100%, while graft loss is 30% with the dense deposit disease and 70% with the C3GN. No evidence of pre-transplant immunosuppressive treatment for which antibody-mediated GN or plasma exchange for those with regulatory factor deficiencies effective in preventing recurrence. Eculizumab has been certain role with variable success for recurrence. However, those patients who have low C3 before transplantation or who have HLA-DQ or DR17 positivity have a high chances of recurrence along with the female gender. Thank you.
Well, I must say they were 3 very fascinating cases. We are over time. I actually just would like to ask Prof. Almani for some final comments on the 2 cases before we wrap up, and perhaps any other of the questions. Thank you, Professor Bhatti or Dr. Bhatti, for answering the questions on the chat. Much appreciated. So I'm going to hand it over to Prof. Almani.
Yeah, thank you. I mean, those 2 cases highlight the workup that we do in patients who have an MPGN pattern. Obviously, this is not a diagnosis, but it's a trigger for you to start workup, and whether you go the complement route or you go the immune complex type route, and that, you know, the staining and the biopsy findings help you look into that. Now, as you know, the cryoglobulinemia case was pretty it's pretty rare. We don't really see it a lot over here, but I mean, it might be common in other parts of the world. Now, as you know, cryoglobulins are basically IgGs, mostly that do precipitate at lower temperature, hence the name. And when I think of treatment for those patients, I guess if that sort of depends on how bad their disease is. So if they have severe renal involvement, life-threatening disease, severe lung involvement, people should think of ways to either remove or to decrease the level of cryoglobulins. So I saw that there are some, UpToDate has some recommendations, and obviously those are expert opinions. They're not, 100%, because there's no randomized trials to assess when to use plasma exchange or pheresis to remove those cryoglobulins. But in anyone with what you think is a severe disease, it is definitely reasonable to use plasma exchange. Now, rituximab takes time to work. As you know, rituximab, if you want to look at B cell depletion, because, we think that the B cells are the ones that are producing those IgGs. In lupus nephritis, for example, B cell depletion with rituximab peaks at 12 weeks. So again, if you have a patient with severe disease, we often use agents that might work a little bit faster until the rituximab works. So in our center, we often use, in patients with very bad renal impairment or patients on dialysis, we often give combination cyclophosphamide and rituximab. Cyclophosphamide because if it's rapid onset of action, and then rituximab because it is a better B cell depleter, and it's the one that's going to prevent those cryoglobulins from being formed down the road. And then I saw a question about monoclonal gammopathy. I think we should rule that out in any patient with a C3 predominant GN, because, the treatment would differ. If there's a series that Mayo published, they're very successful in using anti-CD38 therapy with daratumumab for patients with C3GN who have an associated monoclonal protein. So again, the treatment is sort of directed more towards the monoclonal protein rather than the complement pathway. So regardless of the age of the patient, it will change how you treat those patients. So I would not skip it.
Thanks very much. I think we've run out of time. Prof. Almani, that was an excellent wind up there for the 3 presentations. And Rachel, I'll let you do the closing.
Okay, thank you. Thank you, Dr. Mai. Thank you, Nikki. Thank you all for your valuable contributions and participation today. I encourage everyone to reach out if they have still further thoughts or concern via the WhatsApp group. Thank you again for your time and commitment. Let's continue our progress and reconvene for our next webinar. Thank you so much.
Thank you.
Have a good afternoon, everybody, or evening.
Bye.
Goodbye.